I'm Shannon Puckett May. I'm one of the clinical pharmacy specialists here at Riverstone. This is part 2 of a 2-part lecture on pharmacogenetics, and this second part builds off of the first part. So if you are joining us, joining us today, you might want to go back and review the first lecture. I will recap that here. So today we're going to briefly, as in one slide, review what we talked about in lecture 1. And then we're going to really work on navigating evidence-based pharmacogenetics resources to be able to find drug and dose selection for common psychiatric medications. And then we're going to use that information to guide medication changes and dose selection for common psychiatric conditions. We're really narrowing our scope today because this is how we are going to be utilizing pharmacogenetic testing in primary care at Riverstone Health. So as I previously asked, I'm going to have everybody log in to Cpic, and there are the links with that. Cpic and PharmGKB are the 2 evidence-based resources that we're going to go through the cases with. I also sent out now let's see if I can navigate through here. Can everybody still see what are you viewing right now, my presentation? Darn. So it's not working in that view. We will be going through the GeneSight Psychotropic test panel, so I can give you an example of that, and I'll just have to reshare my screen when we do that. But if everyone can have these websites up so you can more quickly navigate our cases. Did that change? Okay. So a really brief lecture 1 recap of a very long lecture. What is pharmacogenomics? Pharmacogenomics is using genetic information to guide drug dosing and selection. Our goal with pharmacogenomic testing is to maximize the effectiveness of medications and reduce the risk of adverse events. There are the evidence, the genome-wide association studies that we looked at. I showed you the differences between what a genotype and associated phenotype means. Major changes would be patients who are poor metabolizers or ultra rapid metabolizers, which we also have some receptor affinity changes, transporter changes, which have lower levels of evidence. We talked about how other things can play in. So smoking status, smoking, cigarette smoke, and cannabis can alter your enzymes in your liver and increase or decrease the metabolism of medications. So you have to keep those factors in mind. Drug-drug interactions can do something called phenoconversion, which is changing your phenotype from something to a different class based on a significant drug interaction. And then what we'll do is look at the reports, and we'll see that it's not always just that black and white or red, green, yellow type of outcome. When we're looking at the reports, you really need to focus on the guidelines. So there are several classes of medications that are impacted by liver metabolism, but the main ones that we're going to focus on are in the field of psychiatry. Mostly medications used to treat anxiety, depression, ADHD, and then mood stabilizers. In the field of primary care, this is going to be our main focus today. I did talk a lot more, give some examples in chronic pain, and then polypharmacy, but with our implementation at Riverstone, every patient will have testing evaluated, their full med list evaluated by clinical pharmacy. So we would catch this whole realm in primary care, but our focus is on what patients qualify for this and how do we utilize it in our psychiatric patient population. So really what we're looking at for patient selection for pharmacogenetic testing in the field of psychiatry these are the most commonly associated conditions that have evidence for pharmacogenomic testing and the medications associated with the treatment. Typically, it's a patient who has failed adequate medication trials, so you've had them on an appropriate dose for an appropriate frequency and duration, and they're either not meeting their goals of therapy, or they've experienced treatment failures or side effects to multiple medications. And usually when we say multiple medications, we're looking at, 2 or more medications, possibly in the same or different classes. Again, we did talk briefly about larger tertiary centers doing what's called preemptive testing for pharmacogenomics. There isn't a lot of data to support that, although it's a useful tool. I think that there's such an abundance of information about how to use pharmacogenetics appropriately that we might get there. But I think the society guidelines are still kind of behind what the data that we have. So the main panel that we're going to focus on is the GeneSight Psychotropic panel. That's what we'll be offering here at Riverstone. GeneSight categorizes the enzymes, receptors, and transporters with the associated medication classes for major psychiatric conditions. They give you what red, green, yellow on the medication. Green means typically there's not a significant drug-gene interaction. Yellow means there may be a dose adjustment required, or there may be a little bit more monitoring required. Red would typically mean that there's a major drug-gene interaction, that the patient either won't tolerate the medication, or there could be significantly reduced efficacy and a guideline associated that shows consider alternate therapy. It does provide you with subscript text for further information. It doesn't provide you the full information from the guideline, and I'll pull up the GeneSight panel right now. It also doesn't take into account patients' liver or kidney function, concurrent medications, or smoking status. So that all plays in as well. They do go by the Cpic guidelines for their levels of action and strengths of recommendation, and GeneSight itself has a very robust website for you. I did list the website down there that gives actual their clinical trials. So GeneSight does do a lot of studies on utilizing pharmacogenetics data to guide drug dose and selection. And there's a whole website on there, or a whole section on the literature. I'm going to pull up the GeneSight report and walk through that with you. So I think I have to do this. Okay. Okay. So this is a typical GeneSight psychotropic panel. This is a sample patient. What you will see is the medication classes and the breakdown of the medicines that are based on the patient's genotypes and phenotypes. So when a patient brings reports in like this, they often will say, well, Dr. Guire has me on duloxetine, and this shows that I shouldn't be on duloxetine. Why does he have me on that? There's a lot more to it than that. There are these kind of subscripts right here that will show you. So clinical considerations for a 1, for example, are that the serum levels may be too high. You might consider a dosage reduction. Some of the ones over here have more clinical implications. So amitriptyline, definitely serum levels will be too high. There's actually FDA labeling that shows that you might want to adjust therapy, and that this patient might also have increased risk of side effects. It classifies in antidepressants and then goes down to anxiolytics. Benzos, besides diazepam, have very low significant liver metabolism that would warrant any changes based on their genetics. Propranolol, this patient. So the fun thing is when you get more into this, I can tell this patient is a poor CYP2D6 metabolizer based on everything that's showing up here on the right. That's metabolized by that pathway. If you go down, we have our antipsychotic medications and similar clinical considerations on the subtypes. We have our mood stabilizers here. Carbamazepine is actually a human leukocyte antigen test, so HLA. They list the medicines that don't have any genetic interactions, which is nice. And then when you get to stimulant, we'll go through this briefly at the end. Strattera or atomoxetine is probably the one with the highest level of pharmacogenetic implications. In the back of every report, so whether you get it from Mayo, ERA, Avera, GeneSight, they will give you their genotype and phenotype. So this is the helpful information for you to actually go to the guidelines and say, okay, what's this patient's genotype and phenotype? What's the strength of recommendation from Cpic? Do I really have to change their therapy or avoid this therapy? So this Hla testing is for the anti-epileptics like carbamazepine and phenytoin. This patient does have, is positive for HLA star 3101, which puts that patient at a higher risk for Stevens-Johnson syndrome from carbamazepine or phenytoin. These other ones, like this is a serotonin receptor. This is a alpha-2 adrenergic receptor for ADHD medications. This is another serotonin transport gene. Again, the transporters and receptors have lower levels of evidence, but it does play into where the medications fall in the reporting. And then you'll get their actual enzymes. So this patient, you will get their genotype. And if you remember, star 1 is wild type, so normal. So a 1A2 star 1, you would have them express normal metabolism of that enzyme. The major metabolic enzymes in psychiatry are right here. They're CYP2C19 and CYP2D6. CYP3A4, the variance in that, although it metabolizes about 50% of medications, you tend not to see a lot of variance. I would say the variance in CYP2D6 is the biggest implicator of pharmacogenetic change, followed by CYP2C19. And this patient, interestingly, has the SNPs for both. So we're going to be using this report for all of our exercises. And that's what it entails. So this is the testing we will be doing here. Okay, I'm going to toggle back to our lecture. Okay, so we're going to get into the SSRIs, SNRIs, tricyclics in regards to the data for pharmacogenetics. Again, like I said, the important enzymes and the various medications metabolized with guidelines associated are listed here. Major SSRIs that actually have guidelines: paroxetine, fluoxetine, S-citalopram, citalopram, and sertraline are in the guidelines, as well as amitriptyline and nortriptyline for the tricyclics. Bupropion doesn't have a guideline associated, but it's just really easy to remember. It's the only major one metabolized by CYP2B6 for bupropion. The one thing I will point out about bupropion, however, is that it's a strong CYP2D6 inhibitor. Bupropion, when added to a regimen with any of these medicines, phenoconverts a patient to a poor metabolizer and significantly increases serum levels of all of these medications. So whenever you're adding on bupropion, and the cool thing about pharmacogenetics is the more you learn about it, the better you are with interactions. But bupropion changes everything with patients' phenotyping, if that makes sense. And there are other medications that do as well. This table summarizes the the Cpic levels of evidence, levels of action, and PharmGKB levels of action, and then whether or not there's FDA labeling for the medications I just summarized. And if it's an A, it has a guideline associated. FDA labeling is listed separately. If there's actionable or informative PGX in the FDA labeling, that will be in your references, like through LexiComp or UpToDate, it should be. But you can also use PharmGKB to navigate to that actual drug product labeling. And it is dependent on your phenotype. So it's not just anybody with an alteration in this. It's typically if they are ultra rapid or poor, there is a level of recommendation to adjust therapy or avoid therapy. So what I'm going to do now is I want everybody to go to Cpic. and I'm going to go as well, but I want you to get to Cpic. I want you to find the guideline for SSRIs and CYP2D6 and CYP2C19. So going to reshare this. Okay, so from the main site on Cpic, click on guidelines. Tell me if this doesn't change. It's not change. Okay, just a little delay. So if you want to review the levels of evidence and strengths of action that I've already kind of reviewed last time, you can click here. There's a ton of information. You can scroll down. I find Control F is very easy to navigate these websites. But the CYP2C19 and 2D6 SSRI guidelines are halfway down the page right here. And then it'll show you the medications associated. If you click here, is that changing? Oh, you're on the website. Okay. And you click here, and this is the Cpic guideline for 2D6 and 2C19 genotyping. And every guideline through Cpic is organized very similarly. I would recommend reading through a full guideline. I mean, they're only 8 pages long. It gives you a ton of background information. It summarizes the literature for you. It summarizes the testing and like the kind of mechanisms of action and the metabolic pathways and how they're linking the genetic variants to these enzymes. So it's just kind of a good thing to familiarize yourself with a guideline so you know what's included in it. But I like the tables here. So this is going to tell us with CYP2D6, it's one of the enzymes that has an activity score associated. They've adjusted this actually. There's activity scores in between. They now go by 0.25 increments. But these will show you some common genotypes and the associated phenotypes and what the activity score is. Your reports will already give you the phenotype. So in that gene site report, that told me that a star 1, star 2 was the normal metabolizer. But if you can't find it, you know that there's a reference for it. If you remember from last time, CYP2C19, the star 17 allele is makes the patient an ultra rapid metabolizer, and then there are some that make them a poor metabolizer. So how you utilize these tables, you'll already have this information from your report, but what do you do with it? So here's what they show. So for patients on, or if you're thinking about starting Fluoxetine in a patient, there is guideline information that if you are a CYP2D6 ultra rapid metabolizer, that you will have significantly lower serum levels of paroxetine to the point where there is literature showing strong levels of evidence that you will likely not respond to paroxetine, and that you should select a different medication not metabolized by CYP2D6. And an intermediate or reduced metabolizer, you might have higher plasma concentrations with increased risk of side effects. There's no adjustments in therapy except for this could account for why patients may have experienced side effects to paroxetine at higher doses, and may warrant just keeping them at a more conservative dose. We won't talk about fluvoxamine, but it also has a guideline. This guideline is for CYP2C19 and citalopram and S-citalopram in patients who are ultra rapid metabolizers. S-citalopram and citalopram are metabolized by 2C19. Patients who are ultra rapid metabolizers have significantly lower plasma concentrations and more likelihood for therapeutic failure. And you should consider alternate medications not metabolized by 2C19. That's a moderate level of recommendation, and which has considerable evidence. If you're a normal or reduced, it's just a strong recommendation to initiate therapy with normal dosing. And then if you're a poor CYP219 metabolizer, you have higher plasma levels at normal dosing. So you may want to start with a 50% dose reduction, and instead of getting them. These might be patients who experience those higher side effects to the 10 to 20 milligrams of S-citalopram. Sertraline is not solely metabolized by CYP2C19. So although you'll see sertraline in the moderate or significant pharmacogenetics categories on the reports, if you look over here, the classification of recommendations are pretty low, unless they have normal metabolism. So really sertraline, no matter where it falls on a report, if they haven't trialed it, it is usually something we can still use. And that's the SSRI guideline that we will be using. Okay. Am I still in the report? Okay. This is so annoying. So share screen. Okay. So we're going to jump back here. In this presentation, for those that aren't with us live, I did summarize those tables in this presentation, but I'm going to skip through them because it's just a different, they're already in the guidelines that we just looked at. SSRIs that don't have a guideline associated, it's a little bit trickier to find the information you need. For example, fluoxetine is metabolized extensively by CYP2D6, but the labeling for fluoxetine is pretty low levels of evidence. It does in poor metabolizers on the FDA labeling just inform you that when they looked at the pharmacogenetic studies, which is just the in vitro or like a single patient taking a single dose of fluoxetine and then measuring basically their serum levels, what's their associated serum level with that? They have a 12-fold greater AUC of the S enantiomer than normal metabolizers. But when we look at clinical outcomes, it doesn't tell us that we should reduce the dose. However, how many of you have ever used the combination of bupropion and fluoxetine in patients? Probably almost all of you. So in a patient who's not only a CYP2D6 poor metabolizer with higher levels of fluoxetine, you add bupropion to that, which further inhibits that, it will significantly increase the serum levels of fluoxetine and change the metabolites, because fluoxetine also has active metabolites. So although the data is less compelling, you still want to keep that in mind. Duloxetine is dependent on their CYP2D6 and CYP1A2 activity. CYP1A2, what I want you to take away from this is that cigarette smoke significantly upregulates metabolism of 1A2 to the point where in patients where we look at patients who smoke cigarettes and take duloxetine, the bioavailability is reduced by 1/3 in patients who smoke. And we consider that when we're talking about patients and adjusting their duloxetine doses or getting them to higher doses, you have to take smoking status into effect with your dosing of duloxetine. But in the in Cpic, we're just looking at the pharmacokinetics of it. If you're a poor CYP2D6 metabolizer and have poor CYP1A2, you might have 6-fold increase in duloxetine kind of peaks and serum levels. But you have to consider, so just mostly there is no recommendation to avoid therapy, but they may experience higher side effects. Venlafaxine is the same thing. The FDA does have actionable PGX listed, and we'll go through a case on this. So patients who are poor CYP2D6 metabolizers have increased levels of venlafaxine and reduced levels of O-desvenlafaxine, which is basically Cpic. So for those of you that look at these reports and notice that desvenlafaxine is always in the green, like when in doubt in pharmacogenetics, use desvenlafaxine, not necessarily true, but it will always be in the green because it's not further metabolized. You might not convert venlafaxine to the active metabolite, so you might not respond as well and you might have higher risk of side effects. Here's just a summary of bupropion and CYP2B6. Ultimately, use regular dosing unless you're a poor metabolizer, and then you might want to just consider starting with a lower dose or monitoring for adverse effects and decreased efficacy. So bupropion is another medication that is metabolized into an active metabolite. So it might not work as well in patients who are poor metabolizers, and they might have higher risk of side effects like constipation and headaches. So I want everyone to just quickly go to, if you can, the Cpic guideline for tricyclic antidepressants for CYP2D6 and 2C19. And then I'm going to have you go through that guideline while I go through some of these slides. And tell me when you're there. So as we all know, tricyclics already have high rates of adverse effects, right? Amitriptyline seems to have, oh, there's the chat. I will answer your questions a little bit later. But I found the chat, that's nice. Okay, so amitriptyline is a very highly anticholinergic medication. A lot of people don't realize that amitriptyline is actually just demethylated by CYP2C19 into nortriptyline, right here. And so then nortriptyline and all of the metabolites are further metabolized by CYP2D6. So that is why oftentimes you'll see Corey or me possibly recommend just using nortriptyline instead of amitriptyline. Nortriptyline has less variance due to pharmacogenetics and less anticholinergic side effects than the parent compound. However, they both have Cpic guidelines. So if you look in those tables, and I'm not going to change screens, but there is strong levels of evidence for amitriptyline on CYP2C19 and CYP2D6 metabolism status. And the third table in there actually shows you what to do with amitriptyline dependent on both of these phenotypes. It's a really interesting table to me. And usually it involves a 50% dosage reduction or avoiding use either due to tolerability or efficacy. Versus nortriptyline, the only phenotyping that matters is the CYP2D6. All of the tricyclics are actionable for depression. There's less information for neuropathic pain and lower dosing, so do keep that in mind. But if somebody's a poor CYP2D6 metabolizer, there's a strong likelihood that they are going to experience even more significant side effects to the tricyclic antidepressants. And it is very helpful to guide therapy for tricyclic antidepressants. Does anyone have any questions about navigating those guidelines? Any thoughts, any further information for our purposes? You're all pros at getting there now. So we can do some cases. And then this is a summary table of, so COMT, which is basically catecholamine O-methyltransferase, which processes like the catecholamines basically. And then the serotonin receptors, levels of action are very weak for these, but they still play into the reports that you see. So if somebody's SSRI is in a different category based on one of these statuses, you can kind of say, okay, well, there's a little bit less evidence for this, but it may be contributing to why you're a poor responder to the SSRIs. Maybe we need to change you to an SNRI. Okay. I need to hide the answers. So I just want, whoa, okay. I just want whoever can answer this. Actually, now that I can see my chat, you can also put in the chat. But again, Reese's eggs are on the line, so that's a pretty big deal. 42-year-old female is known to have the CYP2C19 *17*17 genotype. She was recently diagnosed with depression, and you want to start her on escitalopram. Is escitalopram an appropriate medication choice for this patient based on her pharmacogenetics only? Yes, no, I don't know. first of all, what do you need to think about? What's the phenotype, right? So anyone have a guess on her phenotype or a knowledgeable guess, answer? Besides Corey? How would you find that information? You could go to the SSRI guideline, right? Or you could find S-citalopram on genes and drugs in Cpic, or you could look at S-citalopram in PharmGKB. So who has an answer for me? You would ask Shannon or Corey.
Yeah.
Okay, I'll give you a hint. This patient is an ultra rapid CYP2C19 metabolizer. Well, Shannon or Corey would say B, no. So this patient with a strong level of evidence is very much likely going to fail S-citalopram because she metabolizes that medication so quickly that it's not going to probably reach appropriate serum levels. You can reference that table directly in the Cpic guideline that we just went through. But this patient is also a CYP2D6 star 1 star 1. Okay, this is really easy. Somebody should be able to answer this for me. What phenotype is a star 1 star 1? Dr. Guire is correct about ultra rapid for CYP2C19. But what's star 1 star 1?
I'm so bummed I missed this.
Okay, Corey, what's star 1 star 1? Star 1 is wild type. It's always normal. That's the expressed normal phenotype, right? So she has expected metabolism on Fluoxetine. Do you think it's an appropriate alternative just based solely on this information? Well, my pregnant son is going to be excited to eat all the Reese's eggs, so yes, it's appropriate. If you think, if just based solely on her genotyping and phenotyping, it's appropriate.
You can check her out, but she does need to see. Let's see if Corey can see
Okay.
briefly, or maybe he would like to do it. Tell him she didn't think she could do telephone.
Jeannie, you're not muted. Okay, so everyone's following along. So now we're going to go to that gene site psychotropic testing that this patient had done, that report I sent out that we reviewed. And I want you to take a look at that. So you have a patient that walks in, and we've had patients that walk in, and Corey and Shannon are not here because we took vacations. And she walks in, she has a medical history significant for treatment-resistant depression and insomnia. She has concerns about her panel and the results showing she should be cautious taking venlafaxine, 150 milligrams XR daily, which has been working very well for her. Her CYP2D6 is star 10, star 10. What do you tell her? So this is where you can use the report. So what is the star 10 in that report that you have up? What's her phenotype for CYP2D6? This is why this talk is better in person. Corey, what's her phenotype? Yeah, so star 10 is poor metabolizer of CYP2D6. That's a big deal. But what did we talk about venlafaxine? There's pretty low levels of evidence. So A, based on her PGX report, it would be recommended we increase to 300 milligrams daily, or should we reduce her dose because she's a poor metabolizer? Or is the fact that she's doing well on her medicine and not having side effects, should we maybe just keep the dose the same? Yes, Sandy, you get an egg. Keep her on it, right? So you don't ever change a patient's therapy based on pharmacogenetics if they're tolerating it and it's working, right? So keep her there, but what I would probably say is probably not further titrate the dose, because then she might experience side effects. Good job, Sandy. Okay. So now the same patient comes back to clinic. She has ongoing issues with insomnia. She's failed trazodone, mirtazapine, gabapentin, hydroxyzine, melatonin, CBT, CBD. You would like to initiate nortriptyline therapy as an adjunct for her depression and sleep. The patient is known to be the poor metabolizer status of CYP2D6. Oh, you get the answer right there because I'm not in presenter mode. Why does Cpic guideline recommend avoiding nortriptyline? So, strength of recommendation to avoid amitriptyline and nortriptyline and CYP2D6 poor metabolizers, because they will likely experience increased side effects. However, if you're just using it for sleep at a very low dose, you could consider like a 10 milligram dose, but titrating it for depression is not recommended. Okay, levels of evidence for mood stabilizers, antipsychotics, a little bit less robust than SSRIs and SNRIs, but a lot of them, the more common ones, specifically risperidone, aripiprazole, iloperidone, actually do have FDA actionable genetics on their FDA labeling. But if you look at the levels of evidence for pharmacogenomics, it's usually, if it's like a B, it's pharmacokinetic data, but still definitely something to keep in mind. Also, the formulation matters, the phenotype matters, as well as concurrent medications. So patients who are, you're going to start Abilify and their CYP2D6 status, if they're poor metabolizers, they should receive half the starting dose and titrate to half the usual dose. So usually we start low and get them up to maybe like 10 milligrams a day. And then the Maintaina, Abilify Maintaina, should have their dose reduced to 300 milligrams from the recommended 400 milligrams. So it's only actionable if they're poor metabolizer status. And that's a common theme with the antipsychotic medications. Same with brexpiprazole and CYP2D6 poor metabolizers, you should cut the dose in half. If they also are on, there's a drug interaction with a CYP3A4 inhibitor, like if you started, well, maybe a bad example, but like fluconazole could further increase the serum levels. And antipsychotics do carry a lot of side effects. So we do want to be careful with the dosing of these medications if we have pharmacogenetic data available. And usually it entails a dosage reduction. Risperidone is just informative pharmacogenomics via the FDA and no actionable levels in Cpic really. And the same with iloperidone, except it is actionable to reduce their dose by 50%. Clozapine, not that we prescribe that often here, but you may need lower doses of clozapine in patients with poor CYP2D6 metabolizer status. And we did go through the prevalence of these SNPs in different ethnic backgrounds, and it is pretty prevalent. CYP2D6 is one of the most variant genes, so you will see it often on reports. What questions does anyone have before we change to ADHD and HLA reactions? Dr. Guire, to answer your cost question, yes, it is a lot less expensive and more widely available now than it ever has been. The panel that we are offering is covered 100% through Medicaid and Medicare with a sliding fee, and the max out of pocket would ever be $300 if you're above the 400% poverty level. And then, so these panels used to be thousands of dollars and take weeks of turnaround time. And now the turnaround time for this panel is 36 hours, and it's a couple $100. So very widely available, which can be a good thing and a bad thing. I don't agree with direct to consumer testing. I think it should always be discussed with a provider or somebody knowledgeable on the field to discuss the limitations and the implications for patients. For attention deficit hyperactive disorder, the only guideline I really care about for you right now is the Strattera guideline. Zach and I had a patient yesterday that I didn't even think about possibly checking a peak plasma level for her, but in a patient who, Zach has a patient who's not responding to Strattera 100 milligrams daily, and he's appropriately titrated her. I'm gonna skip the children's guideline, but I will tell you that pharmacogenetic testing in kids is less recommended at this point in time, although they are continuing to study it. There are guidelines for this. Atomoxetine labeling is pretty clear on the CYP2D6 metabolizer status and how you implement the medication, and getting peak levels and adjusting the dose based on that. And those are moderate to strong levels of recommendations. But we can go to the adult patients. So in adult patients who have ultra rapid to normal metabolism, you would initiate at 40 milligrams a day, titrate more quickly up to 80 milligrams a day. If no response, consider increasing to 100 milligrams a day. And then if no clinical response observed after 2 weeks, consider obtaining a peak plasma concentration, which you want to be closer to 400. If it's less than 200, obviously assess adherence, but consider a proportional increase in dose. And it does recommend, with moderate strength of recommendation, you can go above 100 milligrams a day. I haven't done that before, but it is a consideration, especially in a lot of our patients who have co-occurring substance use disorders, that it could be added or increased. And then on the other hand, if they're poor to intermediate with lower activity scores, they might respond well to lower doses. So lower dosing may be able to achieve the same therapeutic outcomes, but monitoring. So when they look at this in the poor metabolizers specifically, even if they respond, they may have side effects at the lower doses. So if unacceptable side effects, consider reducing dose. There are ADHD receptors that are tested in these reports, and it'll show you if they are good responders to methylphenidate. Again, when I showed you those tables, the levels of evidence are like C and D, but that will play into the reports too, and it'll put methylphenidate maybe in a yellow category, where you might be more inclined to use something like the mixed amphetamine salts instead. Okay, so ADHD patient, this is the same report. Well, this is through Mayo, but I gave you the phenotyping. No, I didn't. Okay, so the Mayo Clinic report that was also attached, just for time's sake, I'll let you know. She came in, she's a 21-year-old female who had pharmacogenetic testing through Mayo Clinic for depression and anxiety at age 18. She was diagnosed this year with ADHD by our team. She also has co-occurring substance use disorder, and you want to initiate Strattera for her. What is the PGX guided recommendation for dosing and titration based on her CYP2D6 genotype of star 1, star 2? So star 1, star 2 is normal metabolizer. Her activity score is normal / extensive. So she's got an activity score of 1.75. So we can go back to that Strattera chart. So she falls right here. And so what we would do is initiate at the appropriate starting dose. We'd increase her to 80 after 3 days, get her to 100. And if she's not responding, we can consider, oh my God, obtaining a peak level, which is obtained, a peak you would get 1 hour after, usually 1 hour after the dose. And then if you do increase it above 100 milligrams a day, you would want to monitor for efficacy. And at that point, you'd probably want to switch therapies. I did want to briefly touch on drug hypersensitivity reactions because this is also included in the testing. So human leukocyte antigen alterations are definitely what we call the ethnogenetics. So the HLA-B star 1502 gene is only in Han Chinese. So in the drug labeling, depending on what your ethnic background is, they will require testing if you're going to use carbamazepine or oxcarbamazepine for HLA. The HLA star A or A star 3101 is also in patients of Caucasian descent. This significantly, having one of these SNPs significantly increases risks for Stevens-Johnson's and toxic epidermal necrolysis, so those cutaneous drug reactions. Having HLA star 3101 and this can significantly increase stress, maculopapular eruptions, Stevens-Johnson's and TENS. And then the association of that, having that reaction is almost, 9 to 1. This is directly taken from the Cpic, so it's either positive or negative. For carbamazepine, if they're double negative, just use it at appropriate dosing. If they're star 1502 negative and 3101 positive, there's a higher risk for Stevens-Johnson's. If they're carbamazepine naive, you want to avoid use and use something else. So these reactions typically occur within 3 months of therapy. If they've tolerated carbamazepine in the past and they've been on it longer than 3 months, you can initiate it. If they haven't and there are no alternatives, you can consider it. And that's the same with oxcarbamazepine. Regardless of their HLA star 3101, if they're HLA-B star 1502 positive, you really want to probably avoid carbamazepine and use something else. However, this is also the same for phenytoin. So if you see carbamazepine and phenytoin on your pharmacogenetics reports in a patient with bipolar, and they have these SNPs, you definitely want to consult the guidelines or somebody who's familiar with that phenotyping. As far as recommendations for alternate therapy, you also want to be cautious. Okay, I already said that with phenytoin. Oxcarbamazepine, you also want to be cautious. And then lamotrigine, we don't usually do the testing for HLA star 3801. We just dose that very low and slow. Okay. So that's the end of lecture 2. Any questions? All right, thanks everyone. I think these slides will also be posted on SharePoint.
Thanks, Shannon. Sorry I was not there to introduce you, but reminding everyone to complete the evaluation for CME credits. Thanks a lot, Shannon.
Okay, thanks.